Hi, I'm Justin Riley. Today on Wisconsin Doctors, part one of our two-part series here at Upland Hills Health about the opioid epidemic. We'll define what it is, who prescribes them, and most importantly, what are the risks. My guest today will include Dr. Joseph Berg, part of the family medicine team at the Mount Horeb Clinic, and Dr. Joseph Hansen, part of Madison Emergency Physicians. It's all coming up right here on Wisconsin Doctors. Stay right here. Welcome back to Wisconsin Doctors. We're here at Upland Hills Health, and this is part one of a two-part series that we're doing at Upland Hills Health on the opioid epidemic. Serious stuff today, and I'm joined by a fantastic team of physicians, the two Dr. Joes, Dr. Joseph Berg and Dr. Joseph Hansen. Welcome, gentlemen.
Thank you.
Thanks. Welcome back, I should say.
Yeah,
it's good to see
glad
you
to be
again.
here.
So, Dr. Berg, I'm going to start with you. Talk to us a little bit about the differences between opioid and opiate. I mean, what are we even really talking about here?
Sure. Opioids and opiates are medicines used to treat pain. What they do is they bind to specific receptors in our brain and our spinal cord to block pain responses in our body. An opiate is a medicine that originally came from the poppy plant.
Sure.
It was synthetic. It was one of the first drugs actually isolated from a plant.
Wow.
Back in the 1800s. And opioids is a more general term to include not just opiates, but other synthetically derived medicines in the same class. So an opiate would be like, the quintessential one is morphine, and an opioid is like fentanyl or something similar.
Okay, so we know what opioids are, and who's typically prescribing these?
So all physicians should be able to prescribe them and should be familiar with them, but we'll mostly see them prescribed by emergency room physicians and surgeons when they deal with acute pain. And just because of sheer volume, primary care physicians are the people that write the most opioid prescriptions.
Because they see the most people.
They
typically.
do, yeah.
And, obviously this is for pain.
Right.
So when does it come to a point where, the ibuprofen, the Tylenol, whatever, is just not working, we need to move up a level? Right. When is the patient ready to move up to that level of using opioids?
So for chronic pains, like what you're talking about, for maybe just really bad back pain or people that have fibromyalgia or chronic headaches, recent evidence has not been very good for use of opioids in a chronic pain setting. They just aren't very effective in treating that pain and keeping that pain away. What it is really effective at using is using in acute pain, like maybe a severe injury like a broken bone or right after a surgery. Also, it's very effective in use in cancer patients or people at the end of their life.
Okay. So, Dr. Hansen, I'm going to turn to you for a moment here because we're talking about chronic pain as being the thing that opioids are best used for prescriptions for. So, what about the emergency department? I mean, obviously, general practitioners are prescribing the largest number of prescriptions, but what about emergency department usage? When is it appropriate for a doctor in an emergency department to prescribe something like that?
So as an emergency physician, we prescribe or give a lot of these medicines in the emergency department. We see very acutely painful things, and this is what these medicines are good for. Just to go back, it's really good in acute pain and good for end-of-life pain, but the chronic pains is really not a good medicine for it. Yeah. So, broken bones to heart attacks, both of those can be extremely painful, and certainly we want to get the patients comfortable. It helps reduce their physiologic stress, makes them more comfortable. It's easier to communicate with a patient. So we use those a lot acutely in the emergency department, give doses by mouth or by IV. And then the question is going home, things are resolved, your broken bone is splinted. How much do you need to go home with is really the question. So often in the emergency department, we write small prescriptions for these, 10 to 15, to get you through the next few days until that acute pain has really improved and you can get onto better management of that pain long term. Let the bone heal, do some physical therapy, things like massage even can help for long-term types of pain. But our goal really is to get the acute pain under control and then give you enough of those medicines to get through the next few days and not have long-term prescriptions for them.
Yeah, absolutely. And I like how you mentioned that it's really helpful in communicating with a patient if they're not in, severe pain.
Right.
You can kind of communicate what's going on. They can communicate with you what their needs are.
Yeah, I mean, you see a patient who is having an attack of a kidney stone, and trying to sit there and talk to them is almost cruel because they're so uncomfortable. So you want to get them comfortable enough that you can have a conversation, get a history, and then work on helping them with a diagnosis. And they certainly thank you rather than asking them their past medical history and lots of things when they're really miserable. So.
Absolutely. We got to take a short break. When we come back, we're going to continue talking about the opioid epidemic here on Wisconsin Doctors here at Upland Hills Health. Don't go away. Welcome back to Wisconsin Doctors. We're talking about the opioid epidemic here at Upland Hills Health. And Dr. Hansen, we've seen a significant increase in the use of heroin over the past couple of years. How has opioid abuse changed from prescription medications to heroin? How did that happen?
That's a really good question, and it's kind of a heartbreaking story of economics and medicine. And 1996 was the first time that a lot of these opioid prescriptions were released and were getting more and more popular. So you saw a huge exponential increase in the use of them until about 2013. So that went along with a lot of abuse, a lot of use of these medicines on the street. 2013, you started to see the first reduction in the prescription of these medicines. So that led to a reduce in supply on the street. And you had a lot of people who were addicted to these medicines and were abusing them. And we know that people who are now using heroin, about 75% of them started with prescription medicines.
Wow.
Either, more likely, they were abused, less often they were prescribed by physicians, but more often they were getting them on the street. So as that supply went down and the cost went up of the pills, heroin came in and filled that void. And it's cheap, it's readily available, and you've seen an epidemic of use in this country, particularly in rural areas. And that's led to an epidemic of overdoses and deaths and lots of heartbreaking stories.
And you talked about how heroin now, if you get heroin now, that's different from what it was 5-10 years ago, because it could be a combination of things that we don't even know what's in it.
Right. One of the challenges I think for people who switched from abusing pills to abusing heroin is that when you take a pill that's developed by a pharmaceutical company, you know what the dose is, you know what you're getting. With heroin, you don't know what you're getting. You don't know how strong the heroin on its own is. You also don't know what it's mixed with. Often they're mixed with other synthetic medicines like fentanyl, which are stronger and longer acting and more potent. And it may also be mixed with something that's not even an opiate or opioid at all. So another medicine that makes you more sick. And that's why these overdoses are really dangerous.
They're complicated. It sounds like they're very complicated.
Very complicated.
What are some of the things that Upland Hills Health Emergency Department are doing to help reduce the risks of abuse and overdoses?
Yeah, so actually I'm really proud of this. The emergency physicians who work at Upland Hills are part of a group of physicians called Madison Emergency Physicians, and we work at a total of 7 regional emergency departments. So that gives us access to a lot of data. So for the last 5 to 6 years, we've been tracking patient visits, and anyone who has more than 10 visits in a year, their charts get reviewed from the various medical chart systems that we use. So we'll compile data from all of our charts and say, this patient has had 10 visits in all of our departments. Is there a concerning pattern? Are these people who have concerning visits for seeking medicines? If they do, we send that patient a letter and we send their primary physician a letter, and that alerts both of them that we're kind of aware that there's potentially a problem. And then their chart also gets flagged, so it's really easy. You open up their chart, immediately you see that they have received a letter and they have this issue. So when they come in for a painful complaint, the discussion becomes much more about how can we help you with this pain that maybe is chronic, or is there an abuse issue that we really need to talk about? And I've had some of my more powerful patient experiences having people say, thank you for asking me this. No one's ever asked me this before. I've been clean for 3 months and I needed a fix, and I came in and I thought I would be able to get a prescription, and thank you for not writing it. and that's really powerful.
Yeah, that's very powerful. So I want to turn to Dr. Berg for a moment here because, you know, we've seen a lot of things on the news lately of anything from, you know, overdoses to just the side effects of using opioids. Can you talk a little bit about, you know, what are the problems here?
Right. So basically, like we've already mentioned before, it's not really well supported in the evidence that use of opioids for chronic pain is good. And one of the main reasons is because it has a lot of side effects, and it leads to dependence and abuse, as we've mentioned. So some of the specific side effects that we talk about, and I can just mention a few, is constipation. The same receptors that are in your brain and your spinal cord are also in your gut, so they can cause it to slow down and you get constipated. If you use, again, the big problem is we're using these medicines not for just a short period of time like is appropriate, but we're using them for months and weeks and years sometimes, and often at escalating doses because people develop tolerance.
Right.
So higher doses for longer periods of time can lead to depression. If you have high doses, you can have 50% increase in depression. Like we'll talk about in a second more, overdoses. Maybe you take an extra pill. Maybe you take one of the pills that you get from your doctor with some alcohol. That can cause an overdose. It increases your risk of heart attack. Lots of the side effects are significant.
Sure.
And ultimately, your body changes when you take these medicines over long periods of time. You need the medicine to function in your everyday life, or you'll have withdrawal. Right. You'll physically feel something that makes you want to take the medicine, and that can lead to addiction. Addiction is when you need to get the medicine from different sources, so you're searching it out. You have consequences from doing that. You maybe overdose, or you lose your job, or you have strained relationships, and then because of even with all those consequences and all that work you do, you continue to use the medicine. That's when you're addicted.
We're going to take a short break here. When we come back, we're going to talk about some of the specific dangers of abuse and overdose of opioids here on Wisconsin Doctors at Upland Hills. Don't go away. Welcome back to Wisconsin Doctors. We are here at Upland Hills Health talking about the opioid epidemic. And I'd like to start with Dr. Hansen for this segment. We talked a little bit about abuse. We've talked a lot about abuse, opioid abuse, and a little bit about overdose. But what truly are the dangers of opioid abuse and overdose?
Yeah, I think this is a really important topic to talk about. We've seen such a rise in overdoses in the emergency department. The way I like to say it, it's not 100% physiologically accurate, but the brain loves heroin more than it loves oxygen. And I think that's a powerful statement. So the risk of an acute overdose is essentially the patients stop breathing and they die.
Wow.
So knowing that, being aware of it, and being able to kind of recognize the signs leading up to that, I think is really important for people as this becomes such an epidemic.
That's huge. The brain loves oxygen more, or the brain loves heroin more than it loves oxygen. Wow. And talk to us, can you go into more detail about what an overdose actually looks like? I mean, you know, I think it's important that people know, you know, if they're at risk of having an overdose, you know, what to look for, what are the signs?
Yeah, so I certainly don't want to, you know, scare people. You take one pain pill, you're not going to overdose. But for people who do have issues with addiction and abuse, and especially as heroin has become more and more prevalent, this is a huge issue. So the first signs of, you know, use of the medicine is to excess are really small pupils. You actually notice people's pupils are quite constricted. They'll seem a little goofy, kind of distracted, and then progress into sleepy. They'll be hard to wake up, even to shouting at them or shaking them. You'll notice after that their breathing really slows and becomes very shallow. If that continues to progress, they may stop breathing or breathe so slowly their oxygen level declines so much in their bloodstream that they sort of turn blue or gray. And essentially what's happened is the medicine or the drug has shut off the brain's response to the rise in the carbon dioxide in the blood and the drop in the oxygen. So those normal things that drive you to breathe, your brain doesn't care about anymore. So they will turn blue, gray, and eventually their heart can't manage the lack of oxygen anymore, and they die.
Wow. So that's not even like a suffocation thing. It's just your brain decides, no, I don't need to breathe anymore.
Right. Your brain is so satisfied by the heroin that you don't need the oxygen anymore.
Real. That's very real stuff. So how can you guys treat overdoses?
So there's a really, I mean, it's a miracle drug. It's called naloxone is the generic name. And Narcan is maybe the more common name that people know it by. It's a trade name. It was developed in the 1960s to use for acute overdoses, and most of the time these were actually in the operating suites, where people would get a little too much or they'd be sensitive to the medicine, and they would give this medicine to help bring the patient out of the respiratory depression, because that's really what you're trying to get, is get the patient to breathe again.
Right.
So what this medicine does in usually minutes, seconds sometimes, depending on how it's delivered, and it can be given as a shot, can be given intravenously, or it can be squirted up the nose, which is more often how it's given for people who are using it in the community. It binds to the receptors that have been blocked by the drug and wakes the patient up.
Yeah.
So you see it used a lot more frequently by police, by EMS providers, and even by people at home who have a family member who has problems with these medicines.
Right.
So we use it in the emergency department, and people wake up. It's a miraculous thing to see someone who was almost dead,
right,
or looked very dead, and now is sitting up wide awake.
Right. And we got to take a short break again, but when we come back, we're going to talk about why it's important to get to the emergency room even after you've had Narcan or naloxone. Don't go away. There's more Wisconsin Doctors coming up right after this. Welcome back to Wisconsin Doctors. We are here at Upland Hills Health talking about the opioid epidemic. And Dr. Hansen, I want to ask you, because we were talking a little bit about Narcan or naloxone and how this is really the miracle drug almost that's the antidote for a lot of these overdoses, for opioid overdoses. But and there are, they're in the hands of the police now. The EMS have it now, so they're readily available and you don't have to go to the doctor to get them. But it's still important that folks get to the emergency room even after receiving this drug. Can you talk about why that's important?
Yeah, absolutely. And we're seeing more and more of this as a response to the heroin epidemic. There's more and more of the Narcan on the street, and it's actually available at pharmacies for folks who have family members who have problems with this, or people who are addicted. So we see a lot more people who have gotten a dose from themselves or from a family member, and it's dramatic. They wake up, they're breathing now. Often they have some withdrawal symptoms, so they seem sort of sick, kind of vomiting. And it's tempting to say, okay, you're better, you can stay home, but that's absolutely not the case.
Right.
The challenge is the medicine, the drug, right? So the heroin, for instance, lasts longer than the antidote.
Wow.
So a heroin overdose can last up to 6 hours. The Narcan or naloxone medicine lasts 30 to 90 minutes. So it's pretty frequent that somebody comes in an acute overdose, we give them a dose of that medicine, and then have to redose them again within that time period. And sometimes have to put them on a drip or a continuous supply of that medicine to help keep them awake and keep them breathing. And sometimes they need to stay in the hospital until it's over. So it's heartbreaking to hear that occasionally someone gets rescued, their life is saved, only an hour later to fall asleep again from this medicine and overdose and die. When if they had come in to be monitored, they could have been saved.
And that's a really, really kind of a wake-up call for some folks to hear, and even for me to hear that the overdose could last up to 6 hours, and the medicine may only last 30 minutes. The antidote may only last 30 minutes, and that falls drastically short of.
Absolutely, and that's why it's so important to get monitored and come and see us. And a lot of laws have changed. Some people used to be scared to come in. I overdosed, am I going to get in trouble? Are they going to call the police? And that's not the case. We just want to help you. It's not an issue of getting you in trouble.
Yeah, absolutely. Dr. Berg, I want to talk to you for just a moment, because I think it's important for people to know what the reality is for how doctors are prescribing some of these opioid medications now. Because on the one hand, they're not just willy-nilly prescribing them to anybody nowadays, because conventional wisdom has changed, things like that. But there are also, a lot of folks who maybe are used to being able to go in and easily get their prescription filled may not be able to do that as well now. Can you talk a little bit about what the process is for somebody who maybe, is experiencing some of those acute pain symptoms and things like that, but and needs to get, a medication to help the pain, but maybe hasn't done it before? Can you talk about what that process looks like?
Right. So again, like you said, the paradigm has shifted.
Right.
It was much easier to obtain these medications before. Conventional wisdom was, hey, they're safe, they're effective, let's use them.
Yeah.
But it's like we've talked about the whole episode. All of these side effects and abuse and overdose has said like, whoa, mate, this isn't what we should be doing. We need to really select the patients that would be appropriate for these medications. So when I see a patient that has chronic pain that I think would maybe be appropriate for an opiate or an opioid medication, it's an hour-and-a-half appointment.
Wow.
It's a long visit where I completely review their pain and medical history, and I use evidence-based guidelines that were developed by people a lot smarter than me to see if someone is appropriate for this medication in the first place, if they are more likely to be abusive. So things that we look for are people that have problems when they're kids, they're maybe abused, people that have mental health problems, people that have alcohol or drug use issues. If you have any of those things, you're likely not a candidate for these medicines. We do a long review of your medical history. We take a very long time, and we really think hard about it. And that's a big change from what we were doing before. So it's not that we don't want to give you your medication, we don't want to relieve your pain, we just want to make sure that you have something appropriate for your pain, and we protect you from abuse.
Absolutely. We're out of time for today, but I want to thank both of you for your wisdom today, and it's been great talking with you.
Thank you.
Next month, we'll be back here at Upland Hills with part 2 of our series on opioid epidemic here on Wisconsin Doctors. From all of us here at Channel 57, we invite you to live longer, live better. We'll see you next time.